phone का password का
So, good evening, friends. Warm welcome to all of you for this important edition of the postgraduate clinics. We have a very important exam case of toxic goiter coming up from Vijay Medical College, Ahmedabad, kindly contributed by Professor Apushpa and recommended by Dr. Modi sir. And we have a very smart resident, Dr. Sauril Jansari, going to present this case. Ladies and gentlemen, we have a very eminent faculty panel for the evening. We expect Dr. Abhinav Sonkar, still held up in the surgery at KGMU Lucknow. He will be joining us shortly. We have the past president of the IAES and the overseas counselor for the ISIS Edinburgh and very active and eminent endocrine surgeon, teacher, and able orator, Dr. Sai Krishna Vittal from Chennai Apollo Hospital and Dr. Vittal's Institute of Endocrine and Laparoscopic Surgery. Welcome, Sai sir. And we have Dr. Muthukumar, again, eminent endocrine surgeon from Madurai Medical College, Madurai. And we also warmly welcome all the other senior faculty here and students who have joined on the YouTube channel also. Dr. Sauril, you will
Yes,
have
sir.
1 hour for the entire discussion to be completed. The first half an hour will be for the clinical part of it, history part of it, and clinical part of it. So you'll be allowed to present without stop till the history part is over, and the faculty will take back to you slides one after the other and ask questions or give their comments and other things.
Yes,
So
sir.
if you find difficult or if you are not able to answer, please tell so. This is a teaching session. This is not an exam, so don't be worried. If you are comfortable, you can answer upfront. If you don't know, please tell don't know. And all the
Yes,
faculty have been with us for many years, so they will be able to give the right answer if we have a challenge.
yes,
And the second half an hour will be essentially for taking care of the management part of it. And of course, the challenges, complications, little bit of recent advances. So an hour
yes,
of
sir.
time is allotted for this case. So we wish you good luck on behalf of the faculty here. I also warmly welcome Professor T. Srinivasan sir, Professor of Surgery, recently retired from Coimbatore Medical College, and
Thank
other
you, sir.
seniors here. So, warm welcome to all of you. And without much ado, we will start the case discussion. Dr. Sauril, please introduce yourself, your unit chief, your head of the unit, and head of the department, and start your presentation. Good luck to you.
Thank you, sir. Sir, I am Dr. Sauril Jansari, second year resident from BJ Medical College. My sir PG teacher is Apurva G. Shah, sir, and Vinit F. Chauhan, sir. Shall I begin, sir?
Yes, please. Faculty, please take over.
Uh, Sir, I'm presenting a case of 38-year-old Hindu female patient residing at Ahmedabad, housewife maker by profession, belonging to lower socio-economic status, presented in OPD with the chief complaint of protrusion of eyes for last 2 years and swelling in front of the neck for last 2 years, sir. So patient was relatively asymptomatic before 2 years. Then she noticed protrusion of tongue, protrusion of eyes, which was gradually progressive over the time, which was aggravated since past 1 month. Patient relative noticed swelling in the front of the lower neck after 1 month, which was insidious in onset, initially smaller in size, approx lemon size, then gradually increased to current size, which was tennis ball size. Patient also developed excessive sweating, decrease in sleep, breathlessness, exertion, and notice decrease in weight in spite of good appetite, for which patient came to civil hospital in Ahmedabad 2 years back and was managed conservatively at that time with medications. For 12 months, patient was on regular follow-up. Patient has improvement in symptoms and gaining of weight. So dosage of medication was tapered down, after which patient has lost to follow-up but continued on the medication. Now patient presented with increased proptosis, increased breathlessness, exertion, and excessive sweating since past 1 month, also associated with bilateral pedal edema. Overall, patient has lost weight loss of 20 kg over last 2 years in spite of good appetite. So patient has no complaint of pain or fever or palpitation or sudden change in size of swelling or hoarseness of voice. Any other swelling in the neck. So patient has no other significant past history. Patient was previously operated 12 years back for the tubal ligation in via open method. So personal history. Patient is vegetarian by diet. Patient has increased appetite since past, sir, after starting of medication. Patient has no regular bowel and bladder habit at present, and patient sleep schedule is sir, regular. Patient LM last menstrual period was 1st August 2025. Patient has irregular menstrual cycles with only complaint of oligomenorrhea 2 years back. Since past 1.5 years, patient has regular cycles of 28 day cycles. Patient has three child, all normal vaginal delivery. Last child is currently 13 years old. Patient has no other family member have similar complaints. Summary of my history. 38-year-old female patient from Ahmedabad came with a complaint of protrusion of the eyes for 2 years which was aggravated since past 1 month, gradually progressive swelling in front of the neck since past 2 years, significant weight loss over 2 years with breathlessness on exertion and excessive sweating since past 1 month, with no any other significant past or family histories. So should I continue with general
No, I think
examinations?
we'll go back to the history.
Yes, sir.
Like what Dr. Kanagwel said, I think we'll go from first slide.
Yes, sir.
Dr. Muthukumar, you have any comments? I'm fine with this first slide.
No, yes, sir. I'm also fine, sir.
Yeah, go to the second slide.
Yes, sir.
What are the conditions? You said the patient has got decreased in weight in spite of good appetite. Whenever a
Yes.
patient comes with such symptoms, what are a couple of conditions which will come to your mind?
Sir, first is sir, diabetes mellitus. Then, sir, in female, anorexia nervosa is also, sir, can be occurred.
No, you should talk about thyrotoxicosis. These are the two things
Yes,
you should bear in mind.
yes, sir.
You are mentioning here about the patient being admitted and managed conservatively and started on medications. What do you mean by it?
Sir, patient was admitted at our hospital, sir, in our unit 2 years back with that complaint. At that time, patient was started on carbimazole 20 mg, sir, TDS, and was discharged, sir, after, sir, 4 to 5 days, sir. Then patient was regularly monitored for TSH levels, sir.
So
Which, sir,
basically, she came to your hospital 1 year back. She was put on 60 milligram of carbimazole per day,
yes, sir.
and you monitored her for 1 year, and
Yes, sir.
subsequently you lost her for follow-up. Have I
Yes.
understood it properly?
Yes. After 1 year, sir, we decreased the dose because of the thyroid level came to normal, sir, to 10 mg per TDS. For after which patient came for 2 to 3 months of follow, but say, after that patient lost to follow-ups.
All right. Was she only on carbimazole or was she on any other medication in
Sir, patient
addition to
was also
carbimazole?
uh, sir, and apart from carbimazole, we have also started sir propranolol 40 mg TDS. Sir.
Why did he not say it? What medication he should say, automatically say number one, number two. What dose of
Yes.
propranolol was given?
Sir, initially it was 40 mg TDS, which was sir for initial 10 days. After which we shifted to patient for the 40 mg BDs.
What was the indication for propranolol in this patient?
Sir, patient has excessive sir sweating, and patient has also sir complaint of sir irritability and sir tremors, sir.
I will not accept answer of sweating and irritability. So for all patients with sweating and irritability, you will give you should say tremors.
Tremors,
Okay,
yes.
that will be your answer. What else would be the indication for a beta blocker in this patient apart from tremors?
Sir, in patient, sir, tachycardia or sir, palpitation.
Okay. Over to Dr. Muthukumar. Anything in this slide, Dr. Muthukumar?
So you admit all patients with hyperthyroidism, or you can manage patients as an OPD basis. So what was the
Sir,
indication
actually,
for admission in this particular case?
uh, sir, actually, the patient, we sir usually manage patient on OPD basis, sir.
Okay.
But patient had his sir complaint was patient was complaining for tremors and sir a protrusion of eyes, and there was a swelling in the neck. So we admitted for the patient for the just for routine workup, sir.
What
So,
Dr. Muthukumar is asking is whether this patient could have been managed without being admitted. That's all he's
yes, sir.
asking.
Yes, sir.
So,
Patient could be
so,
managed without
so your
admission, sir.
answer should be the patient was just admitted for logistic reasons. Okay.
Yes.
Am I right, Dr. Muthukumar?
Yes, sir. Yes, sir. So no, my next question is: so when do you admit a case with hyperthyroidism? What are the
Sir,
indications to admit the patient with hyperthyroidism?
sir, if the patient has any other signs of sir, high fever or any sir, tachycardia, patient has a dysphagia or any breathing difficulty.
See, dysphagia. Does a patient with hyperthyroidism presents to you with dysphagia often? Is it a common
No, sir.
symptom, dysphagia?
No, sir, it is a very late symptom.
Okay, what is the most common cause of dysphagia in thyroid disorders?
Sir, in thyroid, due to sir enlarged thyroid gland. So while patient was try to deglutination, it's a mechanically it's
More commoner than that. When do the patient when do the patient complains of dysphagia rather than a big gland? Okay, maybe in a toxic case. Any other toxic other than Graves? Any other toxic goiter can present with dysphagia patients?
More common in South India.
Sorry, sir, I don't know.
Hello.
Yes, sir.
Yes, sir.
Why dysphagia? Dyspnea is more common than dysphagia.
Yes, sir.
Why dyspnea is more common than dysphagia? Just now, sir asked why there is a dysphagia. What is anatomical relation or any anatomical explanation why dyspnea is more common than dysphagia?
Sir, dyspnea can be occurred due to sir chronic compression by the thyroid. There can
Okay,
be a
even dysphagia
fluctuation.
also occur due to chronic compression. What are the possible reasons?
So now,
Because trachea is made up of fibrocartilaginous structures,
yes, sir.
and it is more anteriorly.
Yes, sir.
And esophagus is made up of the smooth muscle, and that is posteriorly. So esophagus is more compressible. That's what sir was expecting.
Yes, sir.
Okay, continue.
Just don't mention tachycardia like that. Suppose a patient has got 92, will you admit? You should be very specific. Even 92 is tachycardia. When
Yes,
Dr. Muthukumar said tachycardia is a criteria for admission, you should not be very vague. We are allowed to make mistakes here. Try to
Yes,
be
sir.
more specific. You know,
Yes,
if
sir.
I was the examiner, I will ask you, okay, My patient has got a pulse rate of 94. Will you admit? What will your answer be? Will you admit for 94?
No, sir.
No, you should be. I'm just
Yes.
trying to fine
Yes, sir.
tune. Okay.
Yes.
So
Next slide,
Doctor,
please.
does every patient of thyrotoxicosis require propranolol for the control?
So not every person, person with the sympathetic symptoms mostly require the propranolol.
But
Initial
everyone has
stage,
the sympathetic symptom. In a thyrotoxicosis, everyone has got the sympathetic.
Saurav, you just
Does that make
answered.
indication of giving the propranolol?
You answered it previously, no? What were the indications? You said the patient had tremor. That is
tremors and
number one.
palpitation. Yes.
Number two, tachycardia. This is what you
Tachycardia.
mentioned. This is what
Yes,
Professor
sir.
Ajay is asking you to reiterate.
Okay, sir. Sir, in case of patient has complaint of
Usually the
tremors or
propranolol is
palpitation.
for the emergency purposes.
Yes,
Or
sir.
you are preparing the patient, like when you are going for the surgery for these patients, then you start the propranolol few days before. Not
Yes,
as for the suppression purpose which you are giving here. No? So propranolol is usually given as when you are going to prepare for the patient for the surgery.
Yes.
Okay, so you try to control with antithyroid drugs, and
Yes.
when you're going for the surgery, then you will give the patient the propranolol there.
That is one
Yes.
indication. But I
Yes.
also want to add, when the patient has got tachycardia for symptomatic relief, we do give propranolol, just to add, Professor Khanna. So
Yes.
that is another indication. Okay,
Yes.
next slide, please.
Yes, sir.
Then you can add the anxiolytics in these patients. Okay.
Obviously, you
Anxiolytics
can.
are also very helpful.
Yeah, you can add anxiolytics, but definitely. But when the patient has got severe tremor, definitely there's a role for beta blockers in thyrotoxicosis with patients with tremor and tachycardia.
Yes.
Okay.
regarding the admission criteria, the patient has any atrial fibrillation or if the patient develops any cardiac failure because of hyperthyroidism, then that is a definitive indication for admission. Other than that, you can just manage the patient as an OPD, right?
Yes, sir.
Carry on.
So next slide is
Increased breathlessness. For how long did she have increased breathlessness?
sir, see, I have mentioned, sir, since past 1 month, sir.
So in a patient with thyrotoxicosis, you say suddenly presents with increased breathlessness on exertion. What is going on in the back of your mind?
Sir, patient,
Especially with bilateral pedal edema. What are you thinking of, or what should you be thinking of?
sir, patient has started developing symptom of thyrotoxicosis, sir.
No,
Patient has uncontrolled.
even your proptosis is thyrotoxicosis, your palpitation is thyroid, or whatever, your tremor is thyrotoxicosis. But what does the symptom of increased breathlessness on exertion?
It's cardiac symptoms are
You're
increasing.
thinking in terms of some cardiac involvement,
Yes,
especially with increased breathlessness on exertion and bilateral pedal edema. That should be something at the back of your mind. Okay,
Yes,
we
sir.
have clear concepts. And can you comment about the weight loss of 20 kgs over 2 years? Is it significant or not significant?
Sir, it is significant, sir. Patient has a good appetite. In spite of that, patient is taking enough food, sir. In spite that, patient has weight loss of 20 kg over the period of time, sir.
Okay, just because we ask you questions, it doesn't mean you are answering wrong. You should say confidently, yes, it is significant weight loss. Dr.
Yes.
Muthukumar, anything else you want to ask?
Nothing, sir. That regarding the dysphagia, we have just left it there. I think the answer is thyroiditis. Thyroiditis is one of the most and the common cause of dysphagia in any case of thyroid disorders, particularly in case of hyperthyroidism. If it's a thyroidism toxic phase, again you have a dysphagia.
Absolutely.
Manual compression, right?
Remember, you don't need to have a huge gland. Sometimes the gland, leave alone toxicity, sometimes in thyroiditis, the gland will be barely palpable, but the patient will be symptomatic because it is the nature of the disease. The inflammation, what catches the trachea. So the patient won't have a big goiter, but the patient will complain of pressure symptoms like dysphagia. Okay. Next slide.
Yes, sir.
Again, one more. What is the cause of breathlessness? Apart from in thyroid disorders, apart from this one, apart from cardiac cause, what are the other causes of breathlessness in thyroid?
Sir, compression of the recurrent laryngeal nerve, sir.
Compression?
Will that cause breathlessness?
Sir, hoarseness of voice. It will cause, sir, hoarseness of voice.
What
No,
compression will cause hoarseness of voice? You mean to
he
say
is
compression, or
asking.
you want to change your answer a little bit?
So
He is
damage to the
asking
nerves.
what is the other cause of breathlessness. You are answering hoarseness of voice. Now this is asking what did you have for breakfast? You are telling what you had for dinner.
Yes, sir.
His question is something, your answer is something. Please answer his question.
Sir, I don't know, sir.
Over to Muthukumar.
So we have some benign disorders and malignant disorders. If it's a benign, the most common cause would be the retrocerebral extension. If you have a retrocerebral extension, it will cause compression rather than a big goiter. Big goiter, as sir said, big goiter causing compressing the trachea is relatively very, very rare. It is a retrocerebral goiter that can cause compression and cause dyspnea. That's one point. And
Yes,
malignancy, of course, you know, it can be direct infiltration to the trachea or a bilateral vocal cord palsy causing a stridor and breathlessness. Plus, of course, you have cardiac failure because of hypothyroidism.
Yes.
Okay, can we go to next slide, please?
Yes.
Why did you ask for pain or fever?
Sir, to rule out, sir, thyroiditis, sir, as a cause
Okay.
of, sir, neck swelling, sir.
So when do you get pain otherwise in thyroid disorder rather than hypothyroidism?
Yes, sir. Can you repeat the question, sir?
When do you get pain in thyroid? What are the other causes of pain in thyroid?
Sir, if there is a, sir, in long-standing, sir, the goiter, if there is a, sudden enlargement occurs, or there is a, sir, hemorrhagic nodules are present, it
Yes.
can cause, sir, pain, sir.
So
That is the answer.
Yeah, sudden enlargement. The hemorrhage, it is a reason, right?
One is thyroiditis, two is hemorrhage into a goiter. Existing goiter will cause you pain. Sudden change in size of the swelling or
Then why
hoarseness of voice. Okay. What is this? Why do you want to say any other swelling in the neck?
sir, in case of
You're not wrong, but I'm just asking you for
yes,
explanation.
sir, if there are lymph nodes palpable, it can be lateral aberrant thyroid if we do FNSC, sir. It can be a malignant cause, sir. Otherwise, patient has, in case of, sir, other associated cause, there is maybe
See,
lead to the
be very
lymph
simple.
node
Don't
aberration.
use lateral aberrant thyroid. You want to make out any similar swellings, any lymph nodal involvement. Be
Yes, sir.
simple. Simple English is easier. By using terminologies, you'll get caught.
Yes, sir.
Okay, I think you're spending a lot of time on history. Let's go. Next slide. Past history. Why do you ask for history of radiation exposure?
So previous radiation exposure there are more chance of patient developing sir, malignant condition of the neck thyroid, sir.
What malignant condition? What is the
Sir,
commonest malignancy following ionizing? So you should use the words ionizing radiation.
Yes, sir.
What is the commonest malignancy? It may not be related here, but just for knowledge point of view. What malignancy is common following a history of ionizing radiation?
Sir, lymphoma, sir.
No, the answer is papillary carcinoma thyroid.
Okay. Sorry, sir.
When is the risk more?
Yes, sir.
See, for example, I'll tell you. A child is getting history of irradiation between 1 to 5, next 5 to 10, next 10 to 15. Who's at the highest risk? Which group?
Sir, I
And
don't
why?
know, sir.
Huh?
Sir, 5 to 10, sir.
Why? You want to use the middle path, I think. Okay, the answer is The younger you are exposed to, the chance of risk of malignancy is high because between 1 and 5, the cells replicate and ionizing radiations are more effective in causing all these changes. Remember,
Yes.
okay? And there's always a long latent period. Just because you get exposed now, immediately next month you won't come. It takes few years, okay? 5 to 10 years at least. Remember that. Okay?
Yes.
Dr. Muthukumar, anything else you want to ask?
Yes, sir, that's fine. So I think you should come, yes, as sir said, it should be radiation exposure in the childhood. That would be a better thing.
Yes, sir.
Why there is a malignancy after radiation? What is the probable cause?
So due to after radiation, there is a damage to the sir, chromosomes and DNA, sir.
What will happen? Mutation.
Mutation, yes.
Previously, they used to give radiation for benign condition. What are those benign conditions? Now that it is banned.
Exactly. Previously, they used to give for ankylosing spondylitis. Now that is not being used, number one. Nowadays, they even advise people to wear thyroid shields for those who are exposed to radiation a lot. You expose yourself you prevent yourself by using thyroid shields. Typical example of this radiation exposed papillary carcinoma is your Nagasaki, Hiroshima. Now you are fighting Belarus, Chernobyl disaster, or our own disaster in Bhopal, Okay, carry on.
Yes.
Bhopal is mainly chemical, but I'm just saying, yeah, carry on.
Sorry.
Yes, sir.
Previously, they used to give radiation for benign condition. For example, tonsil adenoids, acne.
Yes.
Later on, it was found that
Yes,
there is a development of papillary carcinoma of the thyroid. So now, question for you is that now in the present era, which is the commonest cause of post-radiation malignancy of thyroid? Just now you told lymphoma. So which lymphoma? Just find out. This is MCQ question for you.
Yes.
Continue.
Yes. Sir, personal history.
Is bowel and habits any significant in this patient?
Sir, in case of hyperthyroidism, patient can has sir increased bowel frequency and diarrhea, sir.
Is it diarrhea or more frequency? Which is more common?
Sir, increased frequencies.
Yeah, it is not the consistency, it is more the frequency. Of course, you can have diarrhea, but what is more common is normally if I'm going passing stools 1 or 2 times a day, I may be ending up passing 4 to 6 times a day. Okay, it may not be solid, it may be even semi-solid, but frank diarrhea is unusual unless the patient is really toxic. Okay, so just don't mention diarrhea, it's more the frequency. Okay.
What you will think of any other cause if this diarrhea is there? In a patient who has the thyroid swelling,
yes, sir.
What other things come to your mind? The patient is
of diarrhea in thyroid patient.
One is thyrotoxicosis. 2.
Second one.
Any malignancies?
Sir, medullary thyroid carcinoma.
Medullary carcinoma.
Very good.
Why?
So what is cause for this? What is cause for diarrhea in case of medullary carcinoma of thyroid, and what is cause of diarrhea for thyrotoxicosis?
Sir, in case of thyrotoxicosis, there is an increased sympathetic activity, which leads to increased bowel
So
movement.
which type of diarrhea? In thyrotoxicosis is due to the hypermotility.
Yes, sir.
In medullary carcinoma, secretory type of diarrhea.
Secretory diarrhea. Yes.
Why? What chemicals?
So in medullary thyroid carcinoma, there is increase in the level of calcitonin.
So calcitonin causes the diarrhea. Am I to understand that calcitonin causes the diarrhea?
No, sir.
Don't get caught like that. The examiner is bored. He's just looking for some mistakes. What
I don't know,
what is
sir.
the cause of diarrhea? Is the kinins. What kinin,
Yes, sir.
especially? I
Sorry,
said
sir.
kinin. What kinin do you know?
Sir, I don't know, sir.
Bradykinin and
Bradykinin.
derivatives like that can cause diarrhea. Okay?
Yes.
Okay.
Yes.
Dr. Muthukumar?
So you mentioned something about irregular menstrual cycle.
Yes, sir.
Oligomania. What's the reason for menstrual disturbances in hypothyroidism?
Sir, in case of hyperthyroidism, if TSH levels are increased, sir, TSH and sir, FSH are both have
Pardon
alpha
me,
units.
pardon me, in hyperthyroidism, TSH level is increased, is it? What did you say?
Yes, sir.
No.
No, sir. In case of there is a sir similar alpha in sir thyroid stimulating hormone, sir, alpha bro, which is associated with sir oligomania, due to which sir there is oligomania.
Also, it can directly affect the pituitary ovarian axis as well.
Yes.
That is the hyperthyroidism per se can directly affect the hypothalamic pituitary and ovarian axis. Okay.
Yes, sir.
Now, this is just an observation, and based on that observation, I'm going to ask you a question. We have been discussing for around 20-25 minutes.
Yes,
All
sir.
of us, have used the term thyrotoxicosis sometimes and hyperthyroidism sometimes.
Yes, sir.
Okay, including myself, including Dr. Muthukumar, including yourself and the other faculty.
Yes,
Are
sir.
they the same? Are they different? If kindly explain.
So they are different, sir.
And
Hyperthyroidism
what is hyperthyroidism?
sir, hyperthyroidism is a state which suggests that there is an increased level of T3 and T4 thyroid hormones, sir.
So
And
in thyrotoxic, there is decreased, is it?
yes, sir. No, sir. Thyrotoxicosis is a biochemical and physiological manifestation of this increased hormones, sir.
Oh, so according to you, hyperthyroidism there is increased T3 and T4. That physiological and biochemical manifestations called thyrotoxicosis. This is what
Yes,
you
sir.
are trying to tell. Am I right?
Yes, sir.
Your answer is wrong. Hyperthyroidism means there is increased synthesis and secretion of thyroid hormones by the gland. In other words, the gland is functioning in excess, producing more hormones and releasing more hormones. That is hyperthyroidism. Thyrotoxicosis is a clinical state in which the tissues are exposed to increased levels of circulating hormones of T3 and T4. It may be due to hyperthyroidism or may be due to other causes. I'll give you a classical example.
Yes.
In thyroiditis, okay,
Yes, sir.
what happens? There is destruction of the follicular cells.
Yes.
So what happens? The cells
Transient.
release the preformed hormones.
Yes, sir.
So there is no hyperthyroidism, but the patient is still toxic. You understand? So
Yes,
you
sir.
should know the difference. Hyperthyroidism means the gland is overworking.
Okay.
Thyrotoxicosis means it is a clinical state where there is excess of hormones. It may be due to gland overworking or may be due to other cause. A patient who is taking thyroid tablets, if he takes his excess dose, the patient is still toxic but doesn't have hyperthyroidism. Have I made myself clear? You should
Yes,
have
sir.
clear concepts. Okay. So hyperthyroidism and thyrotoxicosis, there is some subtle difference. Okay. Carry on.
Yes.
Why did you ask for that family history? How is it relevant?
Uh,
Generally, and in
yeah,
this case,
sir, in general, if the patient is living in a hypoiodinized sir belt, matlab, then it can other family members can also be associated with iodine deficiency goiters. Otherwise, the Graves disease is primary hypothyroidism is a genetic condition, so it might be other siblings might also have the same conditions.
Okay. And moreover, nowadays we know both thyroiditis and probably Graves are seen in more iodine sufficient areas nowadays. Previously, which were iodine deficient, who have been supplemented with iodine and become iodine replete, they have thyroiditis and hyperthyroidism, all these autoimmune disorders. So it's a good thing to ask. Dr. Muthukumar, you want to comment anything?
Okay, sir. No issues. You can proceed.
Okay. So we have completed history so far. So are you clear?
Yes, sir.
Carry on now.
So summary of my history. 38-year-old female patient from Ahmedabad came with complaint of protrusion of eyes for last 2 years, which was aggravated since past 1 month, and gradually progressive swelling in front of the neck since past 2 years with significant weight loss over 2 years, and excessive
Okay.
breathlessness and exertion since past 1 month with no any other significant past or family histories.
You don't have to be a rocket scientist. This is a barn door diagnosis. With the history itself, you must be able to give me a diagnosis. What do you think the patient is having?
Sir, patient is having diffuse toxic goiter,
With the history, I said.
okay. Sir, patient is primary hyperthyroidism, sir.
Why do you say primary hyperthyroidism?
Sir, patient has a protrusion of eyes, which are eye signs, which and other eye signs, which are, sir, more towards suggestive towards the, sir, primary hyperthyroidism, sir.
What is primary hyperthyroidism?
So primary hyperthyroidism, sir, the is
Just because of eye,
condition.
you normally don't jump and say.
Yes, sir.
There are other reasons. Tell me.
Sir, in primary hyperthyroidism, sir, gland is overworking from the, sir, initial stage. So patient has the symptoms in early stage, sir, before patient start developing swelling, sir.
So before developing the swelling itself, you get the symptoms. That's what you're trying to convey.
So around the, sir, patient notice the swelling, patient was already have some symptoms, sir.
Make it easy. The goiter and toxic symptoms appear more or less simultaneously. Okay.
Yes.
Whereas in secondary thyrotoxicosis, what happens? The toxicity supervenes on a long-standing goiter. Multinoid. Okay. Carry on. Next. We'll go to
General
examination. Okay.
Yes. Sir, I have examined the patient under adequate light and exposure. Patient is conscious, cooperative, and was oriented to time, place, and person. Patient is fairly built and fairly nourished. Patient temperature is normal by palpatory method. Pulse is 110 beats per minute with regular rhythm with normal force and volume in right radial artery at rest. Sleeping pulse rate at 96 per minute, regular rhythm with normal force and volume in right radial artery. Blood pressure is 118 mm by 78 mmHg in right brachial artery by auscultatory method in supine position. Patient respiratory rate is 18 per minute and patient is BMI is 20, sir.
Anything
Sir,
else?
patient,
General exam? Yeah.
yes.
Finish general exam, then we go ahead. Yeah.
Sir, patient's on general examination, patient palm appears moist and sweaty. Patient has, sir, tremors present over the palms, and sir, patient's lower palpable conjunctiva shows pallor. Otherwise, patient has no sign of clubbing, icterus, sinus, or palpable enlarged lymph nodes, sir.
What is timing of calculation of the sleeping pulse rate? At what time
Come
we
back to the first
calculate?
slide. We'll go. Come
Sir,
back to the first slide.
yes.
Sir
Sir,
has asked some question there.
yes. Sir, to measure the sleeping pulse rate, we measure patient's pulse rate while patient is asleep for 3 consecutive days, and then make an average of it, sir.
Timing, early morning, midnight.
Sir, sir, around 3 a.m., sir.
3 a.m.
Why?
It
Early
requires a
morning,
very
sir.
dedicated doctor or dedicated nurse to do it. Okay. First of all, I'll tell you one thing. Tell me, why do you want to do a sleeping pulse rate?
Yes.
What is the purpose of doing? And then I'll tell you a few words about it later on.
Yes, sir. Sir, the sleeping pulse rate is
Just tell me
while the
why do you
patient.
do it in 1 or 2 sentences.
Sir, replaces the other causes of, sir, increased tachycardia,
What
sir.
cause? To differentiate it from.
Sir, it is due to thyroid. Sir, patient has anxiety, sir.
Yes, in the
Other reason.
olden days, they used to do it to differentiate it from anxiety neurology when they didn't have other biochemical and other means. In the modern era, let me be frank, most of us don't do it. But if the examiner asks, you should know. Okay.
Yes, sir.
Huh?
Yes.
Do you, do you regularly do sleeping pulse rate in your institution?
Yes, sir. We regularly do sleeping pulse rate in our institution, especially before operating the patients.
Okay. You, as long as you do it in an institution, you should be able to tell your examiners. In our
Yes.
institution, we have been trained to do it, but you should know why you're doing it to differentiate it from anxiety neurosis. Okay, right. Dr. Muthukumar, anything else in the general examination? First slide.
Now, regarding this pulse, suppose the pulse is less than 100 or 80-90, still you want to do a sleeping pulse rate, then only post the patient for surgery. So you decide putting the patient to surgery based on a pulse rate, or because you said something about the just before surgery we used to do sleeping pulse rate. That's why I'm interested.
Sir, uh, uh, so normally patient, if it has around 980 or also we doesn't require to do, sir, sleeping pulse rate, but sleeping pulse rate is help to if the patient is on medical management. It is on, sir, adequate medical management or not, sir. It
Personally, I
doesn't.
feel sleeping pulse rate may not help you to differentiate pre-operatively, but if you are doing it in an institution, please continue to do it. Okay, that would be my answer. Next slide.
Yes. Yes.
You said tremors present. Can you tell me a little bit more about the tremors? I would have expected little bit more explanation of the tremors.
Yes.
What type of tremors?
Sir, patient has fine tremors, sir, while holding the, sir, while straightening the hand. Patient's fingers has tremors, sir, which are fine tremors.
No, that is only a tremors. Fingers having only tremors. So you should say fine tremors.
Tremors. Yes.
So when you say fine tremors, there must be some other type of tremor. Then what are coarse tremors?
Sir, coarse tremors occurs while
Give me one or two examples, or one example of coarse tremor. Parkinsonism.
okay.
Okay, or cerebellar disease. Anyway, fine tremors. Don't mention. How will you identify tremor?
Sir, to identify the tremor, I will, sir, first ask the patient to sit and lay her hand straight, sir, and splay fingers. Then I will look for the, sir, any fine tremors.
I would
In case
add
of
one more thing. Put a piece of
paper,
paper. That
in
is a more little bit easier way. You are right. Please put a paper as well, and the finger should be splayed apart, not joined. Okay,
yes,
right.
yes.
What do you think is the cause of pallor in the lower palpebral conjunctiva?
Sir, patient was, sir, due to anemia, sir.
Anemia, you think? Okay.
Yes.
You
So
said there's no clubbing, icterus, cyanosis, or palpable liver. Can clubbing be present in thyrotoxicosis?
Yes, sir. Clubbing can be present in thyrotoxicosis, which is thyroid dermopathy, sir.
Okay, yes, clubbing can be present. Okay. Dr. Muthukumar, over to you.
what about the icterus? Has icterus has anything to do with patients on with the hypothyroidism? Icterus. What is the relationship?
Granulocyte.
Not
No,
hypothyroidism
sir.
per se. Can anything
Yes.
else cause jaundice in patients with hypothyroidism? Those patients on treatment?
You have already given some
Yes, sir.
medication.
Sir, in case of carbimazole, methimazole, it is cause agranulocytosis. It is allergic reaction.
No, no, pardon me. I'm asking about the jaundice, icterus part, jaundice. I
No,
think
sir,
you answered the question, but probably the reasoning is wrong.
You answered the question, but you didn't know the answer.
Your answer is right.
sorry, sir.
Carbimazole can cause jaundice. What type of jaundice is that?
Hemolytic jaundice. Sorry.
You are just telling
Sorry,
the
sir,
answer which
hepatitis.
you don't want.
Sorry, sir. It causes hepatitis, sir, and it can lead.
Pardon me, sorry. Just repeat once more.
Sir, carbimazole is associated with, sir, liver toxicity and hepatitis. Also, propylthiouracil causes liver
See,
toxicity.
both has different actions. Propylthiouracil has a different mode of causing jaundice, and carbimazole has different mode of causing jaundice.
What is
So
what?
that
We don't have time. Tell me what is what.
I don't know, sir.
Muthukumar will tell now.
this is cholestatic jaundice. Carbimazole cause cholestatic jaundice, whereas propylthiouracil can cause even a fulminant hepatic failure. So that is the basic reason why we always use carbimazole rather than propylthiouracil in any kind of treatment. So the first line of drug is usually carbimazole. It's only mainly because of this effect. All other agranulocytosis, other things, it is equally common. Whereas this is caused polycystic jaundice that may cause a fulminant hepatic failure, right?
And usually, if it's going to happen, it'll occur in the first 2 or 3 months. If it doesn't occur in the first few months, it is unlikely to happen. I will not say it won't happen, but it's unlikely to happen. Okay, right? Let's go to the next one.
Yes, sir.
If the patient develops
Sorry, Professor
agranulocytosis,
Khanna has
how
got
do
a
you-
query. Yeah, Professor Khanna, over to you.
if somebody has got the agranulocytosis, clinically,
Yes, sir.
how does he present?
Sir, patient with patient with present with the sir, mostly patient present with the sir sore throats.
Yes.
Complaint of
Sore throat is
pharyngitis.
the most common presentation of that, or the oral ulcers which are there.
Oral ulcer.
Right. Okay. Yeah.
Third
Go ahead.
fever, also you should remember. I mean, we are going to discuss in the management part, sore throat, oral ulcers, fevers. If the patient is on anti-thyroid drugs, you straight away tell them to stop and do a white cell count, especially the granulocytes. Okay? Okay.
Yes, sir.
Explain to us. Next.
Sir, these are sir slides for the sir general uh, inspection of the patient for sir thyroid swelling. Anterior, posterior, and lateral view, sir.
How will you examine a patient in the thyroid? From the front, behind, or side?
Sir, I will examine the patient from the front and behind, sir.
Okay, good. Carry on.
Uh,
You have to explain to us. No use putting only pictures.
Hello.
Yes. Sir, sir,
Hello.
can I? Yes, sir.
Hello.
Yes, sir.
Why to examine this patient from behind? Why?
Sir, sir, to behind from behind. I can, sir, from look for the sir palpate the sir gland bilaterally, sir, and also by fully extending the neck, I can look for the protrusion of eye, sir.
No, no.
No.
Thyroid is asking. He never said
What
examination
is role
of
of
the
thumb
eye.
here and what is role of forefinger?
Yes, sir. I didn't
Hello.
understand the question, sir.
What is
Yes,
role
sir.
of thumb? This is a
No,
standard method, classical method or conventional method. You have to stand behind the patient. You have to keep both thumbs over the occiput
Occiput and yes,
and
sir,
four
occiput,
fingers
and
over
then I
the
four fingers
neck
over the sir, thyroid range. It is a
and four
standard
fingers
method,
over
sir.
the neck. With
Yes, sir, standard method.
with thumb we can flex and extend the neck.
Yes, sir.
And by concavity of the forefinger, thyroid gland is better palpable.
Palpable.
So this is explanation or basis, anatomical basis for examination of the thyroid gland from the behind. From front, for one lobe, which method?
Sir,
Name the method for the single lobe palpation.
Sir, Leahy's method, in which I will use one hand to push the gland to one side and then palpate by the other hand at that side of the lobe, sir, which is prominence.
Okay. Okay, continue.
You want to show us something, I think. You have a video. Show us. We are quite excited to see. Come on, show it.
Sir, it is. Sir, can I go first do the inspection, sir,
Please
part,
tell us.
then
Tell us. Love to hear from you.
so local examination of the neck, sir. I have mentioned the eye signs separately, sir. I have examined the patient under proper light and exposure in sitting position from front and behind. Inspection findings, sir. A diffusely enlarged bilobular swelling present in front of the neck with right lobe greater than the left, sir. Horizontally, it is extending bilaterally till the sternocleidomastoid muscle, and vertically, it is extending from the superior border of thyroid cartilage till the suprasternal node, sir. Patient swelling moves with the degglutination and doesn't move with the protrusion of the tongue. Smooth overlying surface is smooth, sir, with well-defined margins. An inferior border is visible on degglutination. Overlying skin is normal. No other visible swellings in the neck. Sir, I wanted sir, examination and degglutination, sir.
Why should a thyroid gland? I know this is very basic, but I think in a postgraduate level, you'll be forgiven for not knowing very sophisticated things, but you should not make blunders in your basics. Why does the thyroid gland move in deglutition?
Sir, thyroid gland is inside the deep investing pretracheal cervical fascia. There is a Barry's ligament
No.
from the
We are
cricoid.
not. No. We are not sending telegram. Okay, explain to me. Okay, we are not working for the postal service.
Yes. Sir, thyroid gland is encased in the pretracheal fascia, investing
Yes.
layer. In at the swelling, the thyroid is
No, I
encased
understood
in the
only thyroid gland is enclosed in the pretracheal fascia. That's all you told me. After that, explain.
the pretracheal fascia, sir, is attached. So pretracheal fascia is attached to the sir, cricoid, sir, cartilage.
Cricoid?
Sir,
Tell me.
Barry's ligament attached to cricoid cartilage, and it is cricoid cartilage also associated attached to the sir, inferior pharyngeal muscles. So while the degglutination, the muscles are contracted and larynx moves upward, so it takes also thyroid cartilage and thyroid gland it with it, sir.
You are reasonably correct. I'll just summarize. The thyroid gland is enclosed in the pretracheal fascia, and the pretracheal fascia is attached to the cricoid as well as the thyroid lamina. Okay, and when you swallow, all these cartilages move up. So everything which is enclosed in the pretracheal fascia will move. Not only your thyroid, the lymph nodes, any structure within the pretracheal fascia will move. Number one. Number two, you mentioned about Berry's ligament, which is nothing but a condensation of the pretracheal fascia connecting the posterior aspect of the gland to the cricoid. So when this moves, that also moves. The third little subtle point, which may not be given in many books, the isthmus of the gland is closely related to the second, third, and fourth tracheal rings. So when isthmus on the rings, when you swallow, the rings go up. So anything which is adjacent or attached to it will move on. So if you tell two of these three reasons, the examiner will be impressed. Okay. So what are the other structures which move deglutition?
Sir, thyroglossal cyst can move with deglutition. Otherwise, so pretracheal lymph nodes, if enlarged, can move with the degglutination. Subthyroid bursitis can also with
subthyroid. New terms I'm hearing. Subhyoid.
Subhyoid bursitis.
Not subthyroid. When you discover, you can name it. As of now, we know only subhyoid. Okay.
Yes, sir.
Don't
in which condition thyroid won't move with deglutition?
Yes, sir.
In which condition thyroid doesn't move on deglutition?
So in case of sir anaplastic carcinoma of the thyroid, where it is encasing the
any other
surrounding
condition
structures.
again, even in clinical DAS, very big goiter,
Yes.
reverse surgery.
In most cases, it will be restricted mobility. It will move, but it won't move freely. Okay, very rarely, unless it's really stuck. very rarely, but restricted mobility. Now, you said something about the protrusion of the tongue. Why did you ask for that?
So to differentiate,
Community should know the answer.
yes. So to differentiate it from the thyroglossal cyst, as thyroglossal cyst is attached with the so the tongue, it protrudes while the tongue is it moves up while protrudes on the tongue. Sir.
You are talking like a 12th standard. It is attached to a tongue. Tip of the tongue?
No, sir. So foramen cecum, sir. It is
Yes,
attached near the
foramen cecum. You should be specific. These are all MBBS. Okay. So carry on, Dr. Muthukumar.
Yes, sir. Let him proceed, sir.
Okay, carry on, please.
Sir, palpitations. So I will like to confirm my inspection findings with the palpations. Swelling over the anterior aspect of the neck presented with the right lobe measuring approx 8 by 5 centimeter with left lobe measuring 5 by 3 centimeter in size. Overlying skin temperature is normal, non-tender with smooth surface, and 3 lower upper pole of the swelling is present. On horizontal extent, the swelling is extending below the bilateral sternocleidomastoid. Lateral border is not palpable separately. Vertically, it is extending from the superior border of thyroid cartilage to the sternal notch. With swallowing, swelling moves with the deglutination. On deglutination, inferior border of the swelling is palpable.
Just some grammar. It is not deglutination. It is deglutition. Okay. You are writing deglutition once and degglutination other times. And generally, swallowing, you can even give a glass of water. Some examiners may expect that. Okay.
Yes.
Come back. Okay, you finish this. Sorry. You finish this. Yeah.
Sir, the swelling is forming consistency, not fixed with the surrounding structure and moving side to side. No other palpable swelling in the neck. Bilateral carotid pulsation are palpable at normal side, and tracheal is centrally situated.
Come back.
Yes, sir.
Okay. Why did you look for thrill?
Sir, in case of hyperthyroidism,
sorry,
there is
palpated thrill. I have to qualify. You don't look palpated thrill. Yeah.
Sir, because of increased vascularity in hyperthyroid state, there is a thrill over the gland is palpable. So.
Why do you look for it in the upper pole? Why don't you look for it in the lower pole or in the middle?
Sir, in upper pole, the arterial supply is nearer to the upper pole gland. Sir.
Oh, so there is no arterial supply from the lower pole or middle, is it?
Yes, sir.
No, know the answer or do not know the answer?
I don't know the answer.
See, the superior thyroid artery is a direct branch of the external carotid. Number one. Number two, it supplies a greater volume of blood. So that is why you see near the upper pole. Whether it's palpating a trill or auscultating a brewery, that is the go-to area. Okay?
Yes, sir.
Anything Dr. Muthukumar you want to ask?
No, since sir asked this
Where
question.
is the inferior thyroid artery? If
Yes,
the
sir.
superior thyroid is at the superior pole, where
Yes,
is the
sir.
inferior thyroid artery?
Sir, inferior thyroid artery arises from the thyrocervical trunk, and it goes posteriorly to the carotid artery and supplies after dividing it into different branches to the lower pole of thyroid. Sir, it comes from the behind. Sir.
Behind.
Is it at the lower pole or not?
Yeah, sir, it is.
Is it at the lower pole or
branches
not?
are related. Lower pole, sir, it is related to lower, but first divided in branches, and branches then goes to the pole.
Yeah, so it is not at the lower pole.
Yes.
Okay, superior artery is at the upper pole, but inferior is not at the lower pole. And that is also another reason that you always auscultate or hear the thrill at the upper pole. Okay.
Dr. Muthukumar wanted to ask something.
No, that's the same question I also wanted to ask, sir. So I just wanted to ask where's the inferior thyroid artery? So inferior thyroid artery, as sir said, it runs oblique course crossing the recurrent nerves. It can run behind the recurrent nerve or over the recurrent nerve, or it can give branches both above and below to the RL, right?
In fact,
to the surgical artery.
sorry.
Yeah.
Inferiorly, you don't have arteries. You only have the veins, the
Veins.
leash of veins. Okay. What do you mean by on deglutition, inferior border is palpable? What are you trying to tell the examiner?
Sir, on this inspection,
Two words.
the
What are you trying to tell the examiner? Inferior border is palpable. Means what are you trying to tell us?
so it is not a retrosternal goiter.
That's all. That's the way you have to answer. Next slide.
So you will do it at the deglutition time to see for the lower border, to say it is not a retrosternal goiter.
Sir,
What are the various types of retrosternal goiter?
sir, there are the retrosternal, sir, sir, primary retrosternal goiter, which arises from in the thorax. Then there is a secondary retrosternal goiter, which is the extension of the goiter in the from the neck, sir. And there is a plunging variety of the retrosternal goiter, in which there is while the patient deglutinous, thyroid gland, sir, comes out of the thorax, sir.
So if you see the lower border of the thyroid only on deglutition, does that
Yes,
mean
sir.
you are dealing with a plunging thyroid? Plunging retrosternal goiter?
Yes, sir.
So in your case, do you think it is a plunging type of the retrosternal goiter?
Sir,
You can
I don't think
see
so,
the
because
lower
I can
border
also
without deglutition.
Yes, sir. I can see the
Yeah.
lower border
So
without
it is in the neck, in the cervical region only.
Yes,
It is not the retrosternal. And there are no other features of the retrosternal goiter here.
sir.
What other features you can see of the retrosternal goiter?
Sir, in retrosternal goiter, there is sir, patient has difficulty with breathing, and sir,
Features you
engorgement of
see,
neck
he
veins.
asked.
Yes, sir.
Science, clinical science. So what you
Sir,
will see.
engorgement of the neck veins on elevating both the arms by the sir ears.
What is it called? By some.
Pemberton sign, sir.
Not only that, you may have some facial congestion, sometimes cyanosis as well. Okay, right.
Yes.
Here you just said bilateral carotid pulsation palpable at normal site. What do
Yes,
you
sir.
mean by it? And what is your inference?
Sir, bilateral carotid are palpable against the transverse process of sixth cervical vertebra. In case of anaplastic carcinoma, it encases progressed. It encases around the carotid vessels, and which is while that pulsation of the carotid is not palpable, which is a bearish sign, sir.
So only in anaplastic. It won't happen in medullary carcinoma, papillary carcinoma, is it? Only anaplastic will encase, is it?
So more
Yes or
likely, sir.
no?
Yes, sir. Yes, sir.
The answer is any malignancy which infiltrates or encases the carotid pulsations will not be palpable. In large benign goiters, it can displace the carotid. You will feel it, but not feel it normally,
Okay.
probably feel it laterally. Okay?
Yes.
Sorry, Dr. Muthukumar, sorry to have interrupted you.
No, sir, I was about to ask the same question. Why you said only anaplastic? As you said, both any malignancy can.
Any malignancy. If it is going to infiltrate, you will not be able to feel the pulse. That is
Will you able to feel the superficial temporal artery in case if there is a carotid sheath involvement is there? You are not able to feel
yes,
the
sir.
carotid pulsations, but can you feel the superficial temporal?
Yes, sir. I can feel the superficial temporal, sir.
Superficial temporal can be felt, na?
Yes, sir.
Even if you are not able to feel the carotid, but that can be felt. Yes.
Okay, go to the next slide.
Yes, sir. So on auscultation, Bruy was sir, can be auscultated with the bell of the stethoscope or upper pole of the swellings.
Okay, so what does this brew indicate?
Sir, increase blood flow, sir.
Yeah, increase vascularity, that's all. Okay. Next,
Sir, I would like to proceed with the eye signs.
carry on.
Sir, patient has staring look with infrequent blinking present with wide palpable fissure. And sir, on left eye, there is a lead detection present with visible upper and lower sclera, sir. Rest of the signs were examined, but they were not present, sir.
Normally, I'm not a big fan of asking for signs, but please remember, some of the examiners will ask for signs. So you should know the common things about accommodation, Mobi sign, Stellwalk sign, Von Graff sign. Dr. Muthukumar, your views?
Yes, sir, of course. We need to know at least 5 signs. As sir said, at least 5 signs is important. You need to know at least 5 signs in exams. And we have something called as clinical activity score. So
Yes.
anything about CAS, clinical activity score?
Yes, sir. I didn't
Clinical,
understand, sir.
for
CAS,
eyesight, do you know
clinical
anything
activity
about
score.
clinical score?
Yes, sir. Sir, patient मतलब symptoms and according to that, sir, patient score is 90, sir. Patient can do his routine works with minimal symptoms and signs.
Just to update you, there used to be a classification called no specs classification in the olden days. But then that did not tell you the activity. It only showed the severity. So nowadays we have clinical activity score, which tells you whether you've got active eye disease or not. Okay. They will not go into details, but they'll expect you to know the principles. Okay.
Yes.
I will not go. You want to ask anything in the eye science?
No, sir. Just an activity score of more than 3 is, you mean then it is
Active disease.
just to know whether it's active or not. That's all. Nothing more.
Remember,
Yes, sir.
the proptosis in thyroid is called exophthalmos. That is number one.
Yes.
Number
Yes, sir.
two, it is usually bilateral, but it can be symmetrical or asymmetrical, rarely unilateral, rarely. Okay, but usually bilateral, may be symmetrical or asymmetrical. Please remember this. Okay.
Yes, sir. Yes, sir.
What is the
By
incidence
seeing this
of
picture, how do you say the patient has the exophthalmos? Seeing this picture, how do you
Yes, sir.
say it is the patient has a exophthalmos?
Sir, patient has a staring look with the upper and lower lower sclera is sir, visible.
Yeah, you can see the limbus all around.
Limbus, yes.
You can see the white sclera all around the limbus.
Yes.
What is the normal one?
Yes. So no.
In a normal person,
So
how
there
does
is a
it look like?
upper sclera is not visible, and on a there is it covers the
Yes,
pupil
yeah, you are
by
right.
2 mm, sir.
Yeah. What is the objective way of saying this patient has got exophthalmos? Yeah, of course, clinically you can make out. Is there any objective way you can say?
Sir, by objective, sir, Nafzager sign, sir.
Is there an instrument? Let me put it that way.
Yes, sir. There is an instrument. I don't remember the name, sir.
Exophthalmometer.
Yes.
Okay, carry on.
So what is the incidence of eye involvement in Graves' disease?
Sir, it is around 20 to 25%, sir.
Radiologically?
Yes, sir.
Radiologically, clinically,
if you take an MRI, if you take an MRI,
MRI.
what is the incidence of eye involvement?
Sir, I don't know, sir.
It's more than 96 to 98%. Eye involvement in MRI I'm talking about. Most of the patients will not have any clinical signs or symptoms, but MRI can show. So it's like, so nearly most of the patients will have some sort of eye involvement in Graves' disease.
Yes, sir.
But clinically, 30 to 40 will manifest. 1/3 will manifest. You should remember roughly. It's an easy way. 1/3 will manifest. But MRI wise, if you see, there will be subtle changes of inflammation seen in most of the muscles. You will have some evidence of inflammation as well. Retroorbital inflammation. Okay. Let's carry on. I think we are already past the 1 hour, 10 minutes, and Kanagavel will be edgy now.
Sir, this is demonstrations of different eye signs. Should I continue or?
Continue, please. What are you trying to tell me what you are trying to do?
Sir, I have examined the different eye size, which
Tell me what is
sir,
Mobius said. What are you give us a running commentary?
sir, sir, I should start from the first sign, sir.
You start.
Sir, one graphism which is suggestive of while the one second, sir. So one graphism which is suggestive while the patient while the examiner finger is going from the above downwards, patient's upper eyelid is failed to follow the sir eyes. It is due to the involuntary contraction of the Muller's muscle, which is supplied by sympathetic supply. Sir.
So
Which is
basically, you're
overactive.
telling me there's a lid lag.
Yes, sir.
Okay, carry on. Next one.
Sir, Joffre said it is also due to the Muller's muscle. While in this sign, sir, while examiner moves its fingers upwards, there is no wrinkling over the forehead, which is due to due to Muller's muscle contraction. Eyelids are already contracted, so patient doesn't require involuntary to wrinkle the forehead muscles.
Carry on. If you don't ask questions, carry on.
Yes. Then some Mobius, it is seen in a severe condition, severe eye involvement, during which we mostly try to examiner try to go distally to proximally from 1 meter to around 25 centimeter distance near to the finger to the patient and see if the eyes of patient is converging or not. If they are not converging, it is signs of early stage of ophthalmoplegia, sir.
Carry on.
Sir, then other systems, cardiovascular system, patient has sinus tachycardia with normal heart sound with no murmur. Central nervous system, the patient is conscious and oriented. Respiratory system, bilateral air entry present with by no abnormal breath sounds, and per abdomen is soft and non-tender. Should I continue, sir?
Yeah, continue.
Sir, case summary. I am
Sorry,
presenting case of.
you never
Yes,
mentioned about the pedal edema here, whereas you mentioned initially, but there's no evidence
Yes,
of pedal edema now.
sorry, sir.
Am I right?
Yes,
Because you mentioned in the history that a patient has come with swelling of the feet, but in clinical examination, you're not even mentioning that.
Yes.
I'll ask you about pedal edema. Is it bilateral, unilateral, pitting,
Yes,
non-pitting?
sir, patient is
Two diseases I
bilateral.
can ask.
Bilateral, sir, pitting edema, sir. Present is, sir. Sorry, I missed to mention it.
Can you have unilateral pitting edema?
Sir, in case of hyperthyroidism, sir.
So we are
No,
talking
sir.
about hyperthyroidism only now, not
No,
hypo.
sir. No, sir. So because it is a generalized condition, so there will be, sir, bilateral pedal edema will be present, sir.
Any other condition in hypothyroidism you look in the skin? Can you name any other condition?
That is what I wanted to ask.
Sir, clubbing present.
Skin.
And
I'm
sir, there
talking
is
about
palmar
skin.
erythema. Palmar erythema is. Yes, sir.
Pardon me? What is it?
Palmar erythema, more and liver failure.
No.
Other skin
What are the four
conditions.
components of Graves' disease? Tell me the four components of Graves' disease. Number one.
Sir, it's swelling over the neck, sir, with the
That is
eye
swelling over
signs.
the neck.
So eye signs present.
Diffuse goiter.
Diffuse goiter,
Okay.
sir. Diffuse goiter with
Two.
eye signs, sir.
That is two. Three.
Say the pretibial myxedema.
That is the other cause of edema. That's what is it.
So, myopathy and so there is a myopathy.
Myopathy is it. What is the fourth component?
Sir, the
acropathy. What do you mean by it?
Sir, acropathy mentioned as appears as, sir, clubbing of the sir,
Only
fingers.
clubbing? There is subcutaneous tissue is?
Edematous.
Yes, okay. So these are the four components. Classically, all four will not be seen. Generally, you'll have two. Sometimes you'll have the third and fourth. So this is the cause, other cause of edema, not only your cardiac edema. Okay,
Yes.
that is what Dr. Muthukumar is trying to ask you. Over to you,
Yes,
Dr.
okay.
Muthukumar.
So it is orbitopathy, dermopathy, and actopathy. Okay.
Yes, sir.
Okay. So the reason, all because of deposition of glycosaminoglycans. All three nearly the same reasons. Okay.
Yes, sir.
Because I
Yes,
don't
sir.
want to go into further details, lack of time. Yeah, I can proceed.
Yes. Sir, case summary, 38-year-old female patient from Ahmedabad came with a complaint of protrusion of eyes for 2 years, which was aggravated since past 1 month, gradually progressive swelling in front of the neck for 2 years, weight loss since 2 years, and tremors and breathlessness on exertion since past 1 month with no any other significant past or family history. Patient is on medication from physician since past 2 years with going in and out remission. On examination, diffusely enlarged, well-defined swelling with smooth surface and firm consistency present in front of the lower neck, which moves with the deglutination and associated with eye signs.
Diagnosis.
Provisional diagnosis is diffuse toxic goiter, suggestive of primary hyperthyroidism, Graves' disease.
Did you examine the CNS in your patient?
Yes, sir, I have examined the CNS. Sir,
What are the
patient has
features
no.
you examined?
Sir, in CNS, there is irritability and insomnia, irritability present, sir. Patient
Signs.
has.
Tell the signs. Tell
Yes,
the
sir.
various signs which are there
Sir,
in the CNS examination.
tremor.
Tremor, yes. What else?
And sir, Chostek sign and trouser sign
Chopstick
in case
sign.
of sorry, sir. No,
Don't get
sorry.
into trouble now.
No, sorry, sir. No, sir.
Did you examine for the myopathy in your patient?
Sir, yes, sir, I have examined.
Which
Patient has
myopathy you examined? Which
sir,
myopathy you expect in your patient?
Is it distal or proximal?
Sir, sir, proximal
Proximal
myopathy.
myopathy.
50%
How do you do
of
that?
them, either or, just say something. Proximal myopathy.
Myopathy. Yes, sir.
Most of the metabolic conditions not only will only cause proximal, whether it's diabetes, very rarely distal neuropathy is mainly due to nervous problem. Okay, metabolic problems will cause mainly proximal myopathies. Remember that. Even
Yes.
if you do not know blindly, you can blurt out. Okay, carry on.
Did you examine the jerks in your patient? Have you looked for the jerks?
No, sir. Chalks? No, sir.
How will it
I
be?
have
Hyporeflexia, hyperreflexia.
Sir, it will be hyporeflexia, sir.
Exaggerated reflexes.
Okay.
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 I think we all agree with your provisional diagnosis. It's a spotter. We don't need to be a rocket scientist. Okay, we agree with you. Carry on.
Sir, thyroid function test values. The thyroid stimulating hormone levels are 0.01. T3 was 25 and T4 is 4.7, sir, which was
Whenever
more
you give this,
increased.
always give the range in your labs because there will be subtle changes and you will have to specify whether it is total or free as well.
Sir, it is the T3 and T4 as free T3 and T4 levels, sir. And so normal TSH is 0 to 5 milli international unit per liter, and sir, serum T3 is sir no, in our units, sir, it is measured as nanogram per ml, and free
Okay,
T4
it's
is
raised, right?
4.7.
So T3, T4 is raised and TS is suppressed, right?
Yes, sir.
Yeah, proceed.
Sir,
Yeah,
the XL2.
Just come back. Based on this TFT itself,
Yes, sir.
can you say whether it is a hyper functioning gland or not? Roughly. Suppose
Yes,
I
sir.
say
I can say it is a hyper functioning gland because
why?
TSH is suppressed, sir. Thyroid
No.
stimulating hormone level is suppressed.
Okay, I will give you an example. Suppose I say this is a thyrotoxic phase of thyroiditis. Will you agree with me or disagree with me?
Sir, can you repeat the question, sir?
See, we both agree that the patient has got toxicity.
Yes, sir.
Based on this, your T3 is high, T4 is high, TSH is low. So all of us agree that the patient is toxic. Now I want to know, based on this TFT, whether the patient is hyperthyroid or not. Can you say?
So patient is hyperthyroid, sir.
Why do you say so? In other words, suppose I say this is a transient thyrotoxic phase of Hashimoto's thyroiditis, where you will get increased T3, increased T4, decreased TSH. Am I right or wrong?
Yes, sir. You are right, sir.
No, I
In
am
case of early
wrong. I'll explain. Normally, remember this. This is a rough rule of guide. Hyperactive gland. That is when the thyroid is functioning in excess, it produces more T3 in relative to T4. Whereas in thyroiditis, or if you are taking excess of thyroid tablets, your T4 levels will be relatively higher. Here, if you see, your T3 levels are markedly higher when compared to T4. Okay, so
yes.
this roughly indicates that you are dealing with a hyper functioning gland. Okay,
Yes, sir.
carry on.
Understood, sir. Thank you, sir.
If you have got the
Uh,
choice between carrying out total T3, T4,
yes, sir.
or it is free T3 and free T4, you have a choice to do one only. Which one you
Sir, I
will do?
would like to proceed with, sir, free T3 and T4 because
You have a
the
choice
total
of one only. You
sir,
have a choice of only one. Out of these four, you get
yes,
a
sir.
multiple choice question,
Yes, sir.
total and free both T3 and T4. Okay, total,
Free
you will do a
T3,
free T4.
T4.
If you have
Okay,
to pick up one only, you will do
yes,
free
free
T4.
T4.
Okay. Yeah.
Yes, sir. So patient's cervical X-ray and chest X-ray, which is shows no sign of scabbard trachea, sir.
So what is the reason for taking X-rays now with the so
Yeah.
high TFT, with the so high T3 and T4? What is the reason to take this X-ray right now? Why did you take it now?
In other
Sir,
words, will you be the second investigation? You have just done a free TT, T4, TSH. Will you do an X-ray as a second investigation?
no, sir.
So why
Then
did
why
you
do you
take it?
do?
Why did you take it? What is the reason behind taking the X-ray right now with this so high T3, T4?
Sorry, sir.
You
It
don't need to
doesn't
be
require,
sorry.
sir.
It's not your fault.
It
Explain.
doesn't require, sir. In case of if patient has breathing difficulty or then it has importance, sir.
In fact, you can do in this patient, but you should probably show it at the end because you mentioned breathlessness on exertion, pedal edema, nothing wrong. But after your free T4 and TSH, this should not be the second investigation. You got a physiological diagnosis of overactive thyroid. What will be your next investigation?
Sir, ultrasonography, sir. Sir, patient has both lobe and isthmus of thyroid gland appear diffusely enlarged with normal echotaxia, so markedly raised vascularity with sir, right lobe measure 7 by 4, 5 by 6 centimeter and left lobe measure 4 by 3 by 6 centimeters. Isthmus measure 12 mm. Sir.
Did you do any other imaging test?
No, sir, we didn't get any other imaging test. Sir.
Suppose you have all facilities. Say you have every facility. I'm giving you a choice. You can use any facility you want, any radiological, any imaging you want, you can do. What do you do? What will you do?
Sir, sir, radiological investigation or sir, any other investigation?
No, no, I'm just
Imaging
giving
test.
you a I'm just giving you a
Sir, I
choice.
will
You can do
try
any investigation.
to go for the sir, radioactive iodine scan, sir.
It's
Okay.
called radioactive
Radiation
iodine
or
scan.
technetium, which is easier to do nowadays?
Yes, sir, technetium 99 scan is much more easier and cheaper, sir, to do because it has a lower half-life and sir, it can be done within 20 minutes of injection.
20 minutes. That will take 24 hours. Difficult to produce iodine 123. Why do you want to do a technetium scan? You already
Uh,
got a diagnosis of T3 is high, T4 is high, TSH is low. Why do you want to do?
Sir, to rule out any malignancy, sir.
Malignancies.
So-
Aha. This conversation will go to 11 o'clock if you answer like this. That's not the reason you do. What is the purpose of doing a nuclear scan of the thyroid in a case of hyperthyroidism or a toxic goiter?
Sir, to look for the sir any cold nodules or hot
That
nodules,
is
sir.
not the aim. You may look for it. What is the primary purpose? Okay, lack of time to differentiate it from a hyperfunctioning gland, hyperthyroidism, and thyroiditis. Even in thyroiditis, as I told you, there will be a transient thyrotoxicosis.
Yes,
So, in that case, you don't need to give anti-thyroid drugs in
yes,
thyroiditis.
sir.
Whereas in
Yes,
hyperthyroidism, you will have to give anti-thyroid drugs. I gave you a rough idea based on a biochemical investigation how to differentiate. But the real way to do it is to do a nuclear scan of the thyroid. In
yes, sir.
hyperfunctioning gland, you will have increased uptake. Then you may find whether it's diffuse, homogeneous, or heterogeneous, or whatever. Whereas in thyroiditis, uptake will be minimal. So this
Yes,
is the main reason you do a nuclear or technetium scan in a case of hyperthyroidism or a toxic goiter. Have your
yes,
concepts
sir.
very clear.
Yes,
Okay.
yes.
You can talk about cold nodules, all that. That's all secondary in nature. Did you
Yes.
do? You didn't do.
No, no, we didn't do,
Suppose,
sir.
okay, suppose you don't have nuclear scan of the thyroid. You
Yes, sir.
have made a clinical diagnosis of Graves' disease, but are you aware of any other test? Let me put it this way: any other blood test to diagnose Graves' disease?
Any other blood test, sir? Definitive diagnosis would be a TSH receptor antibody test, sir.
Yes, TSS receptor antibody, otherwise called TRAB. It is more than 95% specific, close
Specific.
to 98% specific for Graves' disease. So if you don't have this scan, you can even do this blood test. Okay,
Yes, sir.
Dr. Muthukumar?
What other antibody you can do?
Sir,
What
I
other
can
causes
go.
of thyrotoxicosis?
Sir, we can go for sir thyroglobulin antibody, anti-thyroid peroxidase antibody. Thyroid anti-peroxidase antibody are specific for Hashimoto thyroiditis, sir.
You can do all those, but if you want to
Yes.
do one, this is the one, TRAB. Okay, so the ultrasound done. What is the purpose of doing the ultrasound here? You're not
Uh,
wrong, but just tell me why.
Sir, is there any sir localized nodule particularly sir present or any hemorrhagic collection, sir?
Okay, and
Or any
ultrasound may
cervical fluids?
also pick up suspicious nodules. Please
Nodules.
note, 5 to 10% of cases, toxic goiters can be associated with malignancies.
And see.
So there is a definite indication of performing an ultrasound. Okay, carry on next
Yes.
investigation.
Yes,
Good.
sir, I have one.
Thank you. Okay, forget it.
We have performed.
Okay,
Otherwise, we can go for sir MRI and CT scan.
For
Uh,
this patient, for this patient, for this
for this
patient.
patient, we doesn't
we are
require sir.
talking about only this patient. You have done a TFT, which shows increased T3, increased T4, and increased TSH. And T3
Yes.
is relatively more than T4 in this. Then you have done ultrasound scan. So, what did you do for the management of this patient?
Sir, we have started sir patient on sir again the previous dose of sir carbimazole of 20 mg TDS sir, and with propranolol also. Patient has a particular complaint of patient is not able to go in the public because of sir her staring look and the sir vibrating. There is a sir tremors in the hand, sir. She
Okay,
is not
see, you
performing
have
well in the
given the
public.
anti-thyroid drugs for, if I remember right, for at least 1 year by now. Somebody else has treated, or you guys have treated. So, for how long will you give the anti-thyroid drugs? How long can you normally give? You can give on long term, but generally there's a convention, at least for your exams. What is the maximum duration you will give a trial of anti-thyroid drugs?
So 2 years, I will give the trial of anti-thyroid drugs.
18 months to 2 years. What is the rationale behind giving it for 18 months to 2 years in Graves' disease?
Uh, sir, to exact reason, sir, I don't know.
See, because this is an autoimmune disease, you are trying to decrease the thyroid hormones, and in the meantime, hoping there'll be a remission. Okay, so that is the rationale. Whereas if you give anti-thyroid drugs for your secondary thyroid toxicosis, you can go on giving, it will not remit. In Graves'
Yes, sir.
disease, there's a chance of remission, so that is why
Yes, sir.
you give. Okay,
Yes, sir.
so you will give it for 18 months for 2 years. Okay, remission doesn't happen. What will you do for this patient? Definitive
Uh,
management wise.
Sir, I would like to go for sir total thyroidectomy for this patient, sir.
What are your options and why will you use
Sir,
surgery? Tell me what are the two options available? You are right, but what are the two options available?
sir, the radioactive, sir, iodine ablation, sir, and sir, the total thyroidectomy surgical
Which would you prefer in this
interventions.
patient and why?
Sir, I will prefer operative intervention, total
Why?
thyroidectomy for this patient, because sir, patient has say eye signs are present, sir. That's why it will be aggravated on radioactive iodine therapy, sir.
What happens if you give radioactive iodine? Why should it be aggravated?
Sir, radioactive iodine therapy, it leads to any can lead to initial sir hyperthyroidism or thyroid stones, which can aggravate the symptoms.
So because of thyroid storm, you don't give, is it?
Yes, sir. Sir, more not particularly, sir. I won't like to give
Your
it
eye
because of
signs
the
will get
aggravated eye signs,
worse
sir.
because of inflammation. That is why it's a relative contraindication. It is not the
Yes, sir.
absolute contraindication. So when the eye signs are there, you prefer surgery over radioactive iodine ablation. Okay.
Yes, sir.
What surgery will you do?
Sir, total thyroidectomy, sir.
Totally. Before surgery, what would you want to do for this patient? Okay, you're going to do surgery. What would be your aim prior to surgery?
Sir, my aim prior to surgery, there will be the patient, render patient the youth in euthyroid state, sir.
How will you render this patient euthyroid? What are the avenues to render this patient euthyroid?
So to start anti-thyroid medication prior to surgery with
Okay,
for
that is
repeat
one you
thyroid
mentioned.
stimulation.
What else?
Sir, I can start, sir, on propranolol, sir, patient
How does the
before to prevent.
propranolol help in
So,
surgery? I know propranolol decreases the heart rate and all that, but in surgery wise,
sir, it stabilize the sir cardiac membrane. So, in intraoperatively, sir, arrhythmia, chances of arrhythmia and thyroid storm is also so less, sir.
So with
what
regard to your
will you do?
euthyroidism, you're
Sorry.
talking something. What? You're talking something about the euthyroidism, achieving euthyroidism. So how
Yes,
will
sir.
you say that you have achieved euthyroidism?
Sir, patient. Uh, sir, patient's the serum thyroid profile comes to within the normal range, and patient has sir improvements in the symptoms.
Yeah, yeah. What? So how will the T3 be? How will the T4 be? How will the TSH be?
Sir,
So
TSH will be
you need a normal T3, normal T4, normal TSH to proceed for surgery. Is it so, or is there anything? Is it different?
sir only sir T3 and T4 should be within the normal range, sir.
Yes, very
Free
good.
T3 and free T4.
No, no, no,
Because
not necessarily. Just T3 and T4 is sufficient because for a TSH, for the thyroid axis to recover, it takes a longer time in case of hyperthyroidism. So in hyperthyroidism, we usually don't see the TSH to take the patient for surgery, whereas in hypothyroidism, we usually see the TSH as a marker
Yes, sir.
before going for a surgery. We don't really see the T3 and T4.
the words which we use are the patient should be clinically and biochemically euthyroid. Biochemically euthyroid means T3 and T4 is normal, we are happy. Clinically euthyroid means we want the pulse rate to be under control. Okay, so you mentioned anti-thyroid drugs, you
Yes, sir.
mentioned beta blockers. What are is there any other agent which you know which you do use prior to surgery?
Uh, prior to surgery, sir. I don't know, sir.
Have you heard about that iodine? Is iodine useful?
Lugol's iodine, sir. Lugol's iodine, or SSKI, sir.
No.
Supersede
How
sodium.
is it useful?
Sir, it
First of
renders.
all, there is no big randomized trials to say that is effective, but conventionally many people use it. How does iodine help?
Sir, Lugol's iodine help after giving the Lugol's iodine, it renders the gland firm with decreased vascularity.
That's all. It makes the gland firm and less vascular. What is Lugol's iodine?
So Lugol's iodine is a solution of 5% iodine and 10% potassium iodine, which is given approximately 7 to 10 days prior to the surgery at dose of 7 to 10 drops per day.
How will
with
you
water.
give it? You will just give drops in the mouth like that?
Sir, with water or milk, sir.
You will give it in
Glass
water.
of water. With glass of water, sir.
Normally, it is so pungent. You will give it with milk or orange juice. They will not drink it. You give it one day in water, second day they won't take. You either give it with milk or orange juice. You said that 7 or 10 days. What is the sanctity of 7 or 10 days? Why? I am saying I'll give it for 3 weeks. I want to prepare him well. So I want to give for a month, I'm saying.
Sir, if it is given beyond the 14 days, it can cause, it can aggravate the thyroid storm, sir.
Now just explain to me. Iodine is a raw material for thyroid hormones, and your
Yes.
thyroid glands are overworking to produce excess hormones. And you tell me, I am going to give iodine and that is going to decrease your thyroid hormone. Please explain how is it useful? I do not know the answer.
Sir, it is acts by, sir, part of Wolff-Chaikoff effect, and sir, due to
Don't use names.
leukocyte.
I'll ask what is Wolff-Chaikoff effect now.
Yes.
What is
Sir,
Wolff-Chaikoff effect?
Sir, on the high, on giving the last dose of iodine, the thyroid glands, sir, release of the hormone is and production of the hormone is sir, stopped, sir. Sudden stop.
Yes, you are roughly correct. See, when you give high dose of iodine, what happens? There's increased iodine is transported in the cell. There's also inhibition of organification. There's inhibition of release also. So therefore, the thyroid hormones drop. But this effect is only for 7 to 10 days. So that is why if you give for more than 10 days or 2 weeks, there's a escape phenomena. And you use the term Wolff-Chaikoff effect. That means inhibition of iodine organification and thyroid hormone synthesis on administration of iodine is called Wolff-Chaikoff effect. You should know all these. You roughly know, but you should put it in good words. So you have done all this and you're taking him for surgery. What surgery you said you'll do?
Sir, total thyroidectomy, sir.
Dr. Muthukumar, you want to ask something?
No, sir. So as
Okay.
you said, for regarding this iodine, for practical, for theoretical purpose, what sir said is true. But practically nowadays we don't really use iodine per se. We use iodine only in cases where the primary anti-hyperthyroid drugs fail. For preparing the patient in a short phase, we use that and immediately we take the patient for surgery. Or else we don't use this iodine routinely in our practice.
So you are going to prepare the OT list for next day. And there are 6 cases are there. 1, this patient, 2 gallbladders, and appendix and also. How will you prepare that list?
Sir, I will put the total thyroidectomy patients are first, followed by the gallbladder patient.
Yeah, that's okay. Yeah.
If
So you are going to put this case as the first case. Why?
I don't know, sir, particular reasons.
You know the apprehension which is there when the patients are waiting for the operation?
Yes, sir.
Okay. So it is because of that reason that you have to avoid the apprehension, because if you keep these patients in the later period, they will be so apprehensive, and that is why you sometimes prescribe anxiolytic to these patients. So
Yes,
they are not, because once the apprehension is there, then these patients can go into thyroid storm.
yes.
Okay, that is why they should be taken as the first, and definitely you have to watch these patients very carefully because of the reactionary hemorrhage which can occur. So because of
Yes,
these
sir.
two reasons, you always keep these patients as the first in the OT list.
Yes.
So you've done a total thyroidectomy.
Yes, sir.
What are the complications you may encounter when you do a total thyroidectomy? Just mention them. We are not, I think we are already running behind
Same.
schedule.
Sir, intraoperative, there can be hemorrhage, sir, due to injury to the thyroid artery or superior inferior thyroid artery. On extubation,
So the hemorrhage is normally because injury to the thyroid artery, is it?
mm, no, sir.
Okay, carry on, carry on.
Yes. Sir, it can be there can also be while the extubation due to the tracheomalacia on long-standing goiter. There can be, sir, difficult
No, tell me in this patient,
reintubated.
tracheomalacia is very rare. You should not mention tracheomalacia in the first instance at all. Most of us will have not have seen. I have seen 2 cases and I got many years of experience, I can tell you. In this patient, what will you, common things? What are the
Hemorrhage, sir.
complications of total thyroidectomy? 1, 2, 3.
Sir, there is a hemorrhage or due to intraoperative recurrent laryngeal nerve palsy. A patient can develop hoarseness of voice, and if bilateral laryngeal nerve palsy, there can be difficulty in breathing. There can also be, sir, patient has loss of pitch of the voice in case of external laryngeal nerve injury, and sir, patient has can transient hyperparathyroidism, sir.
Hyperparathyroidism.
Hyper or hypoparathyroidism.
No,
Hypoparathyroidism, sorry, sir.
hyper. Huh? Hypo or hyper?
Hypo, sir. Hypoparathyroidism.
Now,
Transient hypoparathyroidism.
in this patient, okay, carry on. What does the hypoparathyroidism lead to?
Sir, hypoparathyroidism lead to the hypocalcemia, sir.
Now, what I am asking is you are operating on a patient doing toxic goiter. Is the
Have it strong.
hypocalcemia more chance of being severe than a normal patient with total thyroidectomy? Am I right or wrong?
Sir,
See,
no,
you
not
are
no much chance, sir.
operating total thyroidectomy for a multinodular goiter. You are doing
Yes,
a
sir.
total thyroidectomy for a toxic goiter, long-standing toxic goiter. Am I right in saying that the hypocalcemia has more chance of being severe in a toxic goiter? Am I right or wrong?
Sir, I don't know the answer, sir.
See, in toxic goiter, the chance of hypocalcemia is more possible and probably more severe. Why? Have you heard of the term
Sir,
hungry bone syndrome? Apart from your
yes,
parathyroids, what happens? Long-standing toxicity, there is demineralization of your bones.
yes,
Once
sir.
you correct the toxicity, the calcium gets deposited in the bone as well. So the hypocalcemia occurs. Okay.
Yes, sir.
Dr. Muthukumar, you want to add something?
Yes, sir, you're right. Will you continue the anti-thyroid drugs post-operatively?
Sir, yes, I will continue the anti-thyroid drugs post-operatively for around 7 days.
So yeah,
Because
just wait. So what is the
Off
how
light.
does anti-thyroid drug work?
yes, sir.
How does anti-thyroid drug work? What does it do?
Sir, anti-thyroid
Say
drugs
carbimazole.
are,
You are using carbimazole, right? You have used carbimazole on your patient.
sir, sir, carbimazole acts
What
by
does it do?
acting on thyroid peroxidase enzyme and prevents its
Where does it
synthesis, sir.
act? Where
Yeah,
does it act?
So the thyroid gland, sir.
Where
Sorry,
is the
sir.
thyroid gland now?
you've taken out
You
the
have
thyroid
removed it.
gland.
Removed. Yes, sir. Removed.
So
See,
where will it act?
so
So anti-thyroid drugs you will
propranolol,
stop after surgery. Beta blockers, if it's long
I
term
will
you're given,
continue,
you
sir.
will not suddenly stop. You will taper it because they will be reflex or reactive tachycardia.
Yes, sir.
So keep
Okay.
this in mind. There's no role for anti-thyroid drugs post-operatively except in case of thyroid storm. And even then, you don't use carbimazole there. You can use a propyl thiouracil because it
Propylethiosis,
not
In,
only acts in the central, it also acts peripherally in preventing
conversion.
conversion of T4 to T3. Only there you would continue anti-thyroid drugs. Otherwise, anti-thyroid drugs have no role post-total thyroidectomy. Only as sir said, if you put the patient on beta blockers, you have to continue beta blockers to prevent reflex tachycardia. And that also you'll bring down the dosage. You'll slowly taper it and you can stop it in a week or so, right?
The next thing sir said about PTU, the only two indications of PTU. Number one,
Sir, in case of patient wants some pregnant patient in first trimester and like
very good. Pregnant patient in
thyroid
first
storm.
trimester and
Thyroid storm,
toxic storm, thyroid storm. Otherwise, there's no indication of PTU. Okay. Remember that 1 week of anti-thyroid drugs you will use not after surgery, but after radioactive iodine ablation. For that, if you are giving radioactive iodine ablation, normally the anti-thyroid drugs are stopped 1 week before and commenced 1 week later, and you have to continue for some time because radioactive iodine ablation is a slow process. Patient from being hyperthyroid becomes euthyroid and hypothyroid, whereas this is like your T20 cricket. Immediately everything is reversed. So you will not use anti-thyroid drugs. Okay?
Yes, sir.
When does the hypocalcemia manifest?
Yes, sir.
When does the hypocalcemia manifest?
Sir, I don't hypocalcemia, sir, blood levels.
Manifest means when the patient.
When does the patient have symptoms? That's a question.
Sir, after 2 days of post-op period, sir.
So that is in normal cases. Sir is actually specific to this case, hyperthyroidism, Graves' disease.
I don't know, sir.
It can be earlier, as already said. The bones may be hungry and
hungry. It will be
normally hypoparathyroidism will occur in 24 to after 48 hours because the circulating calcium will take over the body requirements. Only after that it will manifest. Whereas in Graves' disease, because of hungry bones, the calcium will get reabsorbed into the bone and the manifestation can be a little earlier. Okay.
And what is the earliest symptom or sign of hypocalcemia? How does the patient present?
Sir, patient hypocalcemia.
You mentioned some before inadvertently.
So, Chvostek's sign or trousers phenomena can be elicited.
The patient will present with a circumoral
circumolar tingling.
Yeah, so that will be the patient presentation there. And then you have to demonstrate all those tests which are there.
Yes. And remember paresthesia in the extremities as well. Circumoral and extremities, very typical. Okay. And then your signs. Okay. I think nearly 1 hour and 45 minutes. I think we should call it a day if Dr. Kanagavel agrees. Dr. Kanagavel, are you there?
Sir, I'm with you. I've been listening all through. Maybe now we should give the candidate an opportunity to clear his doubts or any questions if he has. Dr. Saurabh, would you like to ask any doubts to the senior examiners here or anything you would like to counter check or any facts which you feel still not clear for you, you can ask them.
Sir, one doubt I had, sir. On the day, if we are planning for the patient for total thyroidectomy, sir, should this patient is carbimazole, propylthiouracil, any medication, sir? What is the last dose should be given, sir?
I will give it on the day of surgery. I will give it. It varies. Some people will stop it 1 day before. No big difference, but I usually give it. Suppose I'm operating this morning or this afternoon, I give it on the day of surgery.
Sir, is it a role to give sir steroid before immediately before?
There is a definite role for 2 reasons. There is relative adrenal insufficiency in thyrotoxicosis, point number 1. Point number 2, steroids per se inhibit the peripheral conversion of T4 to T3. So there is a role for steroids, especially preoperatively and intraoperatively. Okay.
Okay, sir. And sir, one last question. Sir, is there any role of subtotal thyroidectomy in case of Sir Graves' disease?
If you want recurrence to occur, you can do subtotal. As of now, they say total or near total, but I will say total thyroidectomy.
That's all, sir.
Anna sir, any comments, sir? We'll call it close, sir.
No, I
Nishi.
think he has
Muthu,
made
sir.
it. Yeah.
Yes, sir.
Yes, you have done a good presentation. No,
And
but
you withstood a barrage of questions by all of us. You've done very well.
Thank you, sir.
Nice presentation, sir. He covered most
Thank you, sir.
of the questions.
With the permission of the faculty, I call the session a close. And thanks to Sai sir, just finishing surgery and spending a couple of hours with us is too much of your help. Muthu, thank you, Muthu, for joining in a short notice. Nishi sir, Panna sir, thank you for joining. We'll meet at another Friday. We are hardly 2 class away from our 300th session. We need to plan.
Very good.
Panna sir, I'll call you what need to be done for the 300th session. I think thanks to all the faculty who have contributed for our long journey of so many hundreds of class. So PGs have been informing their success in the exam. DNB exams results are out, and both the university exam results are out. Best wishes for the upcoming clinical exams also. And please be mindful, November is the NEET SS which have been announced. Don't lose the tempo after writing theory exam. Please sit and study, continue to study, put your efforts for 14 to 16 hours a day at least, so that you get to go into the NEET SS in one go. Because general surgery is once not an end qualification, it's an interim qualification now. So make sure you don't have a gap year or anything. So finish your NEET SS, whatever be the choice. Now it's a general surgery based questionnaire. Concentrate on general surgery in depth like an MCQ pattern. So with all the good wishes from the faculty here, we call the session a close. Good night, everyone. Bye-bye.
Good night. Bye, Muthu. Bye, Ajay.
Thank you,
Bye.
sir. Thank you.
Thank you.